Okay, so I submitted a research grant in 2018 to the European Union and the name of the proposal was Lyme Triad. So discussing the 3 I's, we discussed this yesterday. Infection, inflammation, and damaged immune system. And I think that really is the critical part of this is not just an infectious disease, this is the damage that's done from this infectious disease. So this was the theme of the proposal I put into the ERC. ERC is a European Union high risk, new research grant. And what I'd like to do is just actually present my grant, actually present the comments from the reviewers, and then just discuss the challenges of how it's so difficult to get funding for research in the current situation that it exists with our understanding of Lyme and the lack of awareness of tick-borne infections, the lack of buy-in from the medical community to support research in this area. So anyway, the objectives of my grant that I submitted in 2018 was just to establish a center for a Lyme Research Center to obviously characterize the burden of Lyme and co-infections in Ireland, but we need to do that throughout the European Union and not minimize the effect of disease, but we need good epidemiology, we need good studies, but critically, we need antigen-based tests because as Christian mentioned before, the signs and symptoms are overlapping of these different co-infections. If antibodies either mean active infection or previous infection, and you can have a negative antibody and still have an infection, we need to have antigen-specific tests, because if you have a positive antigen for Borrelia, that means there's replicating bacteria there. If you have a positive antigen for Mycoplasma, that means you have active replicating bacteria present. The next goal of this ERC grant was to establish a link between the medical school and the vet school at UCD and as part of a One Health initiative, because vets are doing a better job of diagnostics and treating co-infections than we are. And then finally, the only way you can study these diseases is to establish cohorts of patients with these infections, cohorts of pregnant women, and follow them up long-term to assess, responses to treatment, to assess long-term outcomes. And then people are going to, quote unquote, non-traditional treatments. And there's thousands of years of history of using herbal products in China. And until 1945, we didn't have antibiotics. We used herbal antibiotics prior to 1945. So I think there's a need to better understand the role of some of these herbal products that are being currently used successfully to get more rigorous studies to understand the role of these quote unquote alternative treatments. And then finally, this is a first world, third world disease. We talk about Lyme in America, we talk about Lyme in Europe, but what about Lyme in Central America, South America, Africa? Tick-borne infections have a huge burden of disease in third world. So we need to get better relationships and better understanding and support from first world and third world countries. We've done this successfully with HIV. We should be doing it with tick-borne infections. So this was the overall objectives of this ERC grant that I submitted. And then, like I said, there's a whole cascade of what we need to do. We need to recognize the disease. We need improved testing. We need clinically directed treatments. We know that these antibiotics are helping people, but we need to understand why they're working. And then we need to look at the global impact of tick-borne infections and partner better with doctors who are taking care of humans, doctors who are taking care of vets, and then doctors and vets in the first world and the third world. This is the way to move forward. So this was the whole cascade. So the challenge obviously is how can we help improve, understand Lyme and overcome the obstacles to diagnosis and treatment. And this slide, which came from from this ERC grant, is there are certain obstructions to diagnosis and treatments. And there's an ongoing scientific debate whether chronic Lyme exists. We brought up the issue of PTLDS, post-treatment Lyme disease syndrome. What does P stand for? Does it stand for infection that's already gone? Or maybe P stands for persistent infection? Or maybe P stands for partially treated infection? We need to better understand this term. PTLDS is being used as a way of denying people ongoing treatment. You've had your 2 weeks of doxycycline, you don't get any more because this is a post-infectious condition. It's not a post-infectious condition. And then the other way that we can challenge, I think, this issue is the human rights approach that Jenna Luchthayer and the patient groups have looked at. Sometimes the best way to challenge the medical community is with science, but when science doesn't work, maybe the best way to challenge the medical community is with advocacy. So I think both work hand in hand. So basically the concept of this Lyme Resource Center, this grant that we were putting together with ERC, was to establish an international collaboration to characterize the burden of disease, to develop antigen-based tests, to establish longitudinal cohorts, to establish, the correlates of infection, correlates of immunity, to link the UCD Veterinary and Medical School to work a One Health strategy, and then to partner with organizations to disseminate the impact of tick-borne infections worldwide. So this was really the challenge that we put together in this ERC grant. So there's lots of questions that we have, recognize the disease, better testing, better treatment, and how do we cure Lyme? So these were the concepts that we approached the European Union with this grant. So interestingly, I just wanted to go through the responses from the European Union in response to my grant. So there was 5 reviewers that reviewed the ERC grant, and the final. So my proposal was rejected, and it was given a score of C, and so it was not proposed. It was not advanced into the final review, which would be step 2. Rankings range from 61 to 100%, and only the top 26 advanced. So basically the comments from the reviewer was this was a program to extend the results of an Irish initiative aimed to support Lyme patient management, not a program originally to perform research. In particular, the panel had concerns regarding an apparent lack of in-depth knowledge expressed in the proposal regarding the theoretical foundation of Lyme disease, lack of a clear hypothesis, and doubts about the feasibility, including a study in a small central country in Belize. So it was rejected. I'll get into more information on my previous grants in other disease areas and where they've gone. But the challenge is when you submit a grant to public funding mechanisms within the European Union and America, you uniformly run into reviewers who are on the committee who reject. So this is reviewer number 1. There were 5 reviewers. The fundamental shortcoming of this proposal is that it implicitly subscribed to an overly broad definition of Lyme disease, which seems to have included a variety of ill-defined co-infections that do not stand up to critical scrutiny, and mainly serves a network group of practitioners in several countries that specialize in the diagnosis of chronic Lyme or some equivalent term. So, comment 1, there are several inaccuracies in my grant. Lyme disease agents are not intracellular organism. There is no compelling evidence that herbal treatments have any benefit for the treatment of true Lyme infection. There is no compelling evidence that so-called co-infections are as common as the PI supposes. And then finally, there is no justification for including a performance site in Belize, which has no documented evidence of Lyme or any other infections that are transmitted by Ixodes in either North America or Eurasia. My outlandish suggestion suggests a flawed understanding of the epidemiology of Borrelia burgdorferi and related spirochetes. The proposal presents no evidence that the ticks that transmit Lyme disease or anaplasma even occur in Belize, or if they do occur, that they would bite people. So my review was rejected because there are no ticks in Belize. The Belize ticks, if there were ticks, do not carry anaplasma. And even if they did carry anaplasma, there's no evidence that these ticks would bite people. So this is the scientific review received by the response to reviewer number 1, which basically resulted in me being rejected. So it gets better. So in assessing my ability to conduct groundbreaking research, I was scored as non-competitive. So when I submit grants for other disease areas, for example, HIV, to the NIH, through the Institute of Human Virology, which I did in the past, I received an R01, which is a top American grant, looking at chemokines and disease progression in children with HIV. I received a 1.2 million NIH grant. I just completed a successful 3-year European Union Third Health grant looking at hepatitis C for 2.4 million. And in light of the COVID response, submitted a grant to the Irish HRB and just received a 220,000 grant. So I'm unable to do I can do ground-baiting research on other diseases, but not in tick-borne infections. So next, to what extent have the achievements of the PI typically gone beyond state-of-the-art? The answer is non-competitive. So my early days in America was working on pediatric AIDS. I was principal investigator of the Pediatric AIDS Clinical Trials Group at Johns Hopkins. I was involved in sentinel studies that resulted in our better understanding of HIV transmission from mother to child, that resulted in kind of a groundbreaking studies showing that if you had an undetectable viral load in a pregnant woman who was HIV positive at delivery, then the baby was not infected. The results of that study resulted in rollout of HIV treatment for all pregnant women. And this study was published in the New England Journal in 1999. However, my achievements are non-competitive according to this. So most importantly and damaging, I think, is the summary from reviewer number 1. The PI appears to be a follower of the movement of Lyme literate physicians and ILADs that identify chronic Lyme in many more individuals than would be justified by the responsible and rational application of consensus guidelines for the diagnosis and management of related infections. The PI is entitled to his opinions and the promulgation of these as he sees fits. But for scientific scrutiny, I'm sorry, I can't even read this. Promulgation he sees fits, but for scientific proposals of merit, such conjecture should be backed up with empirical evidence and a more vigorous research plan. But actually, my opinion is we need science, not empiricism, to win the day. So this is just, I'm showing you what happens when you try to submit a publication, going through the peer review process. When you submit an application for a grant, through the peer-reviewed process, unfortunately, grants are denied. So there was 5 reviewers. The second reviewer gave me an average to good score. And reviewer 3 to 5 gave me 100% superb score. So the challenge is like I said, is that when you submit grants for or attempt to get publications into the public domain, you are rejected. So grants currently for tick-borne infections cannot be obtained through public processes. Publications cannot be obtained with the current peer review process, is because the reviewers are politically charged. I've never seen a disease so politically charged. Hepatitis, no. HIV, no. Tuberculosis, no. COVID, maybe. But still, there's lots of challenges moving forward to do better science. The only way that we can get funding at the present time is through private funding. So Cohen Foundation in the Bay Area AIDS Lyme group provide research money for USA researchers, but only USA researchers. They only fund USA investigators. They don't fund Canadian, they don't fund European. So my opinion is better science will only come when the saboteurs are neutralized, and you know, we have to find a strategy to move forward with this. The European Union funding mechanisms are paid for by our taxpayers' money. So I think they work for us, and we need to find a way to get them to be more supportive of the work that we're doing. So finally, I just wanted to make a couple of comments on comments by reviewer number 1 that herbs don't work. So there's lots of literature, and I'll just go through some of the slides I have at the present time. Before 1945, antimicrobial herbs were used. And this is a slide looking at some of the slides of the products that work for Borrelia, for Bartonella, for Babesia. So there is data that in vitro, many of these agents work. And I think herbal products, we need to study them better, have antimicrobial, anti-inflammatory, immunomodulating effect. Do we understand well, you know, how these are working? We need to understand better, but we need resources and we need research money to do that. So lots of different products. Cryptolapsus, you know, has activity against a wide range of you know, infections, Borrelia, Bartonella, Babesia. Japanese knotweed, and studies have been done, in vitro studies have been done through Cohen Foundation money given to Johns Hopkins to look at these products. Anti-inflammatory agents, immunomodulatory agents, you know, in terms of herbs and mushrooms, and adaptogens. So there's a wide range of herbal products that studies have shown have in vitro activity. Observation is that they have in vivo activity, but the next step is to have rigorous studies to be able to support the value of these products that many of our patients are using because they are denied the opportunity to get, you know, the longer course antibiotics which work as well. Finally, I just wanted to make a few comments on the reviewer number 1 talking about ticks in Belize. This is a slide. Belize has 10 different UNESCO sites in terms of archaeological reserves, and this is one of their premier sites. This is called Cajalpac. So Cajalpac in the Aztec language means the field of ticks. So ticks have been around. So reviewer 1 needs to go take a trip to Belize. So there were ticks historically for thousands of years. The Aztecs were aware of it. I was down there in Belize. And this is a picture of myself and my son. And the lady on the left is the WHO director of Belize, who is a colleague of mine. So I've worked in Belize for many years on projects. And this is a picture of Jenna Lush there. who is one of our strong advocates, who came down to Belize with us. So while the reviewer number 1 rejected my grant, saying Belize is not a country where ticks exist, the Aztecs knew well about ticks, but reviewer 1 did not know. I have worked extensively with the Minister of Health of Belize, Martin Marinella, over the last 10 years, worked on projects. I provided data on anaplasma to this ERC grant. Currently, University of Notre Dame and Mayo Clinic is working in collaboration with the Belize government looking at tick-borne infections. So while reviewer number 1 seems to think there are no ticks, there is no anaplasma, and ticks don't bite humans in Belize, this is an issue. Borrelia is not an intracellular bacteria, according to this reviewer number 1. We heard information yesterday from one of our speakers about the intracellular role of these bacteria. So how do we get further with our research? And I think the answer is patient advocacy is a critical component here. Science will not win the day as long as we run into people like reviewer number 1, who seems to be controlling the scientific agenda at the present time. So I've actually then looked at who the panel of the committee who reviewed my ERC grant was, and this is the list coming from all Herigens on down, and what I'm going to be doing as a next step is actually communicating with these panelists to see why they are refractory to looking at Lyme disease, tick-borne infections, chronic infections, because an ERC grant is supposed to be exploratory, new science. But this is the challenge. The challenge is, you know, we need to have a better understanding. We cannot get a better understanding as long as the disease doesn't exist, and every time we submit a grant, we are rejected. So the Lyme Triad, as I said, is infection, inflammation, damaged immune system. We critically need better diagnostics, antigen-based. Lyme is just one of the infections contributing to these multi-system illnesses, which are called chronic fatigue syndrome, fibromyalgia, atypical rheumatoid arthritis, and PTLDS has been used as a term to say that there is no ongoing infection in these conditions. And I would say that the P stands for partially treated or persistent infection. And unfortunately, there are no current guidelines for the treatment of tick-borne infections other than early infection. Lyme disease guidelines are only for early disease. 2 weeks of doxycycline, 3 weeks of doxycycline. There's no recognition in the medical community that these infections have a chronic stage. However, Q fever has a chronic stage, but Borrelia, according to the medical community, doesn't, anaplasma doesn't, and we have to rewrite the textbooks of infectious disease to get where we want to. So I think veterinarians have better knowledge of these infections. We need to work in partnership with these. We do need longer courses of antibiotics. They're being given all over the world under the counter. It needs to be done in an open and transparent way. And we need to better understand why these antibiotics are getting people better. And then finally, the NICE guidelines, which have been put together in the UK to really limit treatment. They're not very nice guidelines, they're very nasty guidelines. And if you look at the guidelines that have been used by NICE, NICE only considers references from 2000 on. Most of the studies on Lyme disease, the good studies, were done prior to 2000. So international bodies refer to the NICE guidelines as a standard of care. They use the NICE guidelines for congenital Lyme. Most of the data on congenital Lyme comes from before 2000. So if you exclude all data from 2000 and before, you will actually eliminate the concept of chronic Lyme you'll eliminate the concept of congenital Lyme. So I really do think that we should ask the English Public Health Service to be investigated about their, putting together nice guidelines that are exclusive and not inclusive. And ultimately, the WHO, who are supposed to be supporting in the world and the health of patients in the world, are ultimately to blame because there is no transparency, and congenital Lyme is an example of this, and we'll be discussing this afternoon at my presentation. So I've gone over, but I just want to stop now and just raise the issue that this is a challenge, and I think we need partnerships with One Health, partnerships with vets and doctors, partnerships between the scientists and the community, because it's a challenge. Thank you.